Today I'll be talking about the newer paradigms in the treatment of resected EGFR mutated early lung cancer. Next slide. So 1 in 3 patients in NSCLC present with resectable disease. This is definitely not Indian data, but is the leading. This rest of it we know. Next slide. So outcomes definitely needs improvement, and surgery is the primary treatment for patients with early stage NSCLC. I'll be talking about 1B, 2, and 3 most commonly. And adjuvant cisplatin-based therapy is a recommendation for patients who treated stage 2 to 3 NSCLC with stage 1B disease also. And overall disease recurrence or death following surgery in adjuvant chemotherapy remains high across the disease stages. Next slide. So what is the 5-year recurrence rate by stage? In 1B, it is 45. 2B, resected regional locally advanced, it is 62 versus 76% if it goes to stage 3. Next slide. So based on a limited number of studies, the presence of EGFR mutation appear broadly similar across the disease stages, where overall estimated prevalence in Asians is around 30 to 40%, with Caucasians being 10 to 20%. And I don't know, but obviously the stage-wise, the prevalence will not change much. But if EGFR TKIs were available in the resected settings, a similar proportion of patients may be able to benefit compared to the advanced setting. This is what I mean by this slide. Next slide. So this was the EDURA trial, which talked about osimertinib as adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. Next slide. So I'll just talk about this slide in detail, where EDURA was a phase 3 study, which included the key inclusion criteria was more than 18 years, WHO performance status 0 to 1, confirmed primary non-squamous NSCLC, exon 19 or L858R, brain imaging if not completed preoperatively, complete resection with negative margin, and max interval between surgery and randomization, 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. And stratification was by stage, EGFR status, that is exon 19 versus 21, and race, Asian versus non-Asian, were randomized into osimertinib versus placebo, and planned treatment duration of 3 years, with treatment continues until disease recurrence, treatment completed, or discontinuation criteria met. Follow-up until recurrence, week 12, 24, then every 24 weeks to 5 years, then yearly. After recurrence, every 24 weeks for 5 years, then yearly. Next slide. So the key inclusion and exclusion criteria staged as 1B to 3A, central confirmation of mutation. Standard post-operative adjuvant chemotherapy consists of a platinum-based doublet for 4 cycles maximum, was allowed but not mandatory. Complete surgical resection and CT or MRI of the brain prior to surgery, and performance status of good performance status. The key exclusion criteria was prior treatment with pre or post-op radiation, pre-op chemo, EGFR TKIs, or any CYP3A4 inhibitors less than 3 weeks prior. Time between surgery and randomization not more than 10 or 26 weeks. And patients who have only segmentectomies of wedge resection, and cardiac criteria including factors that will increase the risk of QTC prolongation or any arrhythmic events, any evidence of severe or uncontrolled systemic disease, and medical history of ischemic lung, interstitial lung disease, or any other malignancies. Next slide. So I'll skip the patient characteristics. They were mostly matched, and even the adjuvant chemotherapy, yes, no, between the osimertinib and placebo arm was almost similar. Next slide. So this was where osimertinib, the ADURA trial, DFS, which was the primary endpoint, versus placebo in resected EGFR mutated NSCLC. You can just see the curves and no need for any explanation. The hazard ratio are hardly 0.17 and 0.20 in the primary population as well as the overall population. Next slide. So there was an 83% reduction in risk of disease recurrence or death with osimertinib, and in the overall population, 80% reduction. Next slide. So if you look at across the stage, the 2-year DFS was much better in the osimertinib arm as compared to the placebo arm, with the hazard ratio being highly significant. Next slide. If you look at the subgroup, rarely do we see a waterfall plot where everyone has benefited, regardless of what is it. Everyone, it's on the left side, all the curves except stage 1B, where understandably it is a little closer, and L85 does a little worse than EGFR exon 19 deletion. Next slide. The one slide previous to that. So early snapshot, overall survival in patients with stage 2 to 3A, although the data is yet to mature, but still, even in this, the hazard ratio has started showing benefit towards osimertinib, and patient and investigator remain blinded to treatment in order to facilitate assessment of OS at maturity. Next slide. So EGFR TKIs in the adjuvant settings, NSCLC, DFS, but not OS benefits have been demonstrated. There have been various studies, but all of them come with some riders. Next slide. In ADURA, the another thing which happens is the type of recurrence is a key consideration in resected NSCLC. In next slide. So if you look at the ADURA, 11% of the osimertinib arm had DFS events versus 46% of patients in the placebo arm. And in the osimertinib arm, majority of patients with recurrence had local or regional recurrence only, with only 38% of the patient having metastatic recurrence compared with 61 patients in the placebo arm. What I mean by this is, if obviously a local recurrence is a easier to treat recurrence as compared to a metastatic recurrence. Next slide. And if you look at the CNS as a site of disease recurrence, which is obviously gives a very bad prognosis, it is much less in the osimertinib arm because it has the highest brain penetration in the TKI sectors versus in the placebo arm. Next slide. So the same thing. Next slide. If you look at the CNS DFS in the overall population, obviously, since the CNS recurrences are less, the CNS DFS is going to be very high. Only 1% had a CNS recurrence. Next slide. Now, the last of it, safety summary. Is there anything which is very strikingly different? Next slide. So basically, we should understand that many of these patients have been post-adjuvant chemotherapy, so they will have some residual side effects of that persisting. Other than that, grade 1 to 2 interstitial lung disease was reported in 10 or 3% of the patient of osimertinib arm, and QTc prolongation was reported in 7% of the patient in osimertinib arm and 1% in the placebo arm. These were something which struck apart. Next slide. So post-operative chemotherapy use and outcomes from ADURA, osimertinib as adjuvant therapy for resected EGFR mutated NSCLC. Next slide. So overall, 60% of the patients received adjuvant chemotherapy for a mutant duration of 4 cycles, and majority of the patients received platinum-based chemotherapy, most with stage 2 and 3A disease. And adjuvant chemotherapy was more frequent in patients aged less than 70 as compared to those above 70. Next slide. So 1B patients were less treated with adjuvant chemotherapy as compared to the other arm. But DFS in patients with or without adjuvant chemotherapy, if you look at both the arms, so irrespective of the fact whether they received adjuvant or chemotherapy or not, the DFS improved. Next slide. And if you, again, except in 1B where it approaches close, in rest of the 2 and stage 3 disease, it doesn't matter with or without adjuvant therapy, osimertinib did benefit all of them. So it is not only the adjuvant chemotherapy which is helping out, or because it was matched in both the arms, but it was the osimertinib which is giving them the DFS benefit. Next slide. Next slide. So DFS in patients with and without adjuvant chemotherapy, I'll just talk about stage 2 more than anything else. You can just see both the curves are so wide apart separating that even without adjuvant chemotherapy in stage 2, although it falls slightly, but it is still significantly better as compared to placebo arm. Next slide. Similar things in stage 3A, although the number of events or patients who did not receive adjuvant chemotherapy was less, so number of events were less, so data is not exactly very telling, but yes, the DFS benefit persisted. Next slide. So patient-reported outcomes. Next slide.
One more minute, Nikhil.
Yes, sir. I'm just about to finish. Yeah. So what were the patient-reported outcomes? This is a quality of life methods where, next slide, HRQOL SF36 survey was used. And if you look at that, the compliance rates with SF36 survey were high in both osimertinib and placebo arm, and both arm almost overlap each other. Next slide. And the time to deterioration of physical and mental component, both the osimertinib as well as the placebo arm, they're almost on top of each other. Next slide. So by that, I'll just summarize. Adjuvant osimertinib is the first targeted therapy in a global trial to show a statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, 2, and 3A EGFR mutated NSCLC. Overall, there was an 80% reduction in risk of disease recurrence or death with osimertinib. Osimertinib versus placebo DFS rates at 2 years were 89% versus 52%. It demonstrated a clinically meaningful improvement in CNS DFS compared with placebo, and the safety profile was consistent with established safety profile of osimertinib with mild EGFR TKI side effects reported. Next slide. A clinically meaningful DFS was observed with or without adjuvant chemotherapy. Higher disease recurrence rate in placebo arms who received adjuvant chemotherapy to those who didn't, likely driven by a large proportion of patients with stage 2 and 3A, as disease is a prognostic factor for disease outcome. And overall, the quality of life indicators showed no meaningful deterioration in quality of life with osimertinib. So the ending thought is adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B, 2, and 3A EGFR mutated NSCLC after complete resection. Thank you.
Thank you, Dr. Nikhil. I think this does make a case for all of us, at least in the patient profile.